Hi everyone, our third mitral valve talk covers the echo assessment of mitral stenosis. So in terms of causes, rheumatic mitral stenosis is by far still the most common etiology, though depending on where you live and work, rheumatic fever might actually be quite rare. And the other causes of mitral stenosis are actually quite rare. So mitral stenosis may be something that you don't see very often, particularly if you work in the developed world or developed countries. For rheumatic mitral stenosis, the main mechanism is commissural fusion. Other anatomic lesions, including caudal shortening and fusion, leaflet thickening, and later superimposed calcification can occur. In degenerative or calcific mitral stenosis, the main lesion is annular calcification. But annular calcification usually has few or no hemodynamic consequences in terms of stenosis and usually causes MR actually. As for the other causes, the main mechanism in these is leaflet thickening and restriction, and these include congenital, inflammatory, and infiltrative diseases. The grading of severity is much more straightforward than with mitral regurgitation, which we talked about last week. So severity is graded with a combination of valve area and mean gradient, with the valve area being the most specific value. Pulmonary artery systolic pressure is also used as a supportive finding. These values in the table here are according to the American Society of Echo. So the normal mitral valve area is 4 to 5 centimeters squared. Mild disease is classified as a mitral valve area of 1.5 to 4. And in that range, a patient would rarely have symptoms. Moderate mitral stenosis is with a mitral valve area of 1 to 1.5 centimeters squared, and severe mitral stenosis is when the mitral valve area is less than 1. A mean gradient of less than 5 millimeters of mercury is mild disease. A mean gradient of 5 to 10 millimeters of mercury is moderate disease, and greater than 10 is severe disease. And the relevant pulmonary artery systolic pressure thresholds are listed there for you. As always, we need to assess the valve anatomy in 2D and in multiple views. And specifically, we need to assess and comment on the thickness of the leaflets, the mobility and motion of the leaflets, calcification of leaflets if it's present, whether or not there's commissural fusion, and also comment on the subvalvular apparatus, so chordae thickening, fusion, and shortening. There are grading systems, including the Wilkins score, which is displayed on the slide. I don't think remembering it's essential for ICU purposes, but what is essential is to describe and document what you see clearly and comprehensively. So firstly, valve area. Valve area can be assessed by the following methods. So with mitral valve polymetry, and this is the reference value if there's any discrepancy in other measurements. Pressure half-time can measure valve area, and we'll also talk about the continuity equation and PISA. Polymetry and pressure half-time attract level 1 recommendations from the American Society of Echo, and the other two measurements can be added in as required or desired. So mitral valve polymetry, as I said, is listed as the reference value for mitral valve area. The measurement is performed in the parasternal short axis. We perform it in 2D, but it can also be performed in 3D and 4D by skilled operators, but that's beyond my scope of practice. The optimal timing of the cardiac cycle to measure polymetry is mid-diastole, and you need to zoom in and use a frozen image. But before that, as part of that process, you need to pan through the valve from apex to base, or apical side to basal side, to find the narrowest aperture of the leaflet tips, because that's really what you want to measure. Because as you can see with these red lines that I'm adding on the image at the bottom, there's a difference in aperture here compared to here. So you want to really make sure that you're imaging and therefore measuring at the smallest aperture. Perform several different measurements if you can, in particular in patients with atrial fibrillation when the aperture of the valve can vary a little bit. As I said, the normal mitral valve area is 4 to 5 centimeters squared, and an mitral valve area of greater than 1.5 usually doesn't produce any symptoms. Advantages of this measurement are its accuracy and independence from other factors. The disadvantages are that although it looks simple, technical expertise is actually required, and you need practice. So if you can or have the opportunity, practice this measurement even in patients that you don't suspect have mitral stenosis, because you may not see a lot of patients who actually do have mitral stenosis. And unfortunately, this may not be a feasible measurement if acoustic windows are very poor, and that can happen when there's very, very abnormal valves with lots of calcification. It can be really hard to work out where the edge of the valve is. So pressure half time is the next method of measuring mitral valve area. And pressure half time is the interval in milliseconds between the maximum mitral gradient in early diastole and the time point where the gradient is half the maximum initial value. So the decline of velocity of diastolic transmitral flow is inversely proportional to the valve area. And MVA, mitral valve area, can be calculated by the equation 220 divided by the pressure half time. So you obtain this by using the apical 4-chamber view and using continuous wave Doppler through the mitral valve, and then tracing the deceleration slope of the E wave on the continuous wave Doppler spectral display of that transmitral flow. And then we're so lucky, the machine will calculate the mitral valve area for us. Sometimes the deceleration slope is biphasic, which you can see on the left side of the white diagram. So sometimes it's biphasic with a rapid early diastolic drop, and in these cases the advice is to extrapolate the linear portion of the E wave and then measure that line, which you can see on the right side of the diagram. The advantages of this are that it is reasonably easy to perform. It's something that we've already learned how to do, or it's a picture that we've already learned how to take, and we can just add this measurement on top. So it is pretty straightforward. And even with not amazing 2D images, you can usually get reasonable spectral Doppler displays at the mitral valve, and therefore you can still make this measurement. The disadvantages of this measurement are that the diastolic filling rate, which is reflected by that E-wave deceleration slope, depends on the MVA, mitral valve area, which is what we're interested in, but also on the mitral pressure gradient in early diastole, and left atrial compliance, and also left ventricular diastolic dysfunction. So the half time is shortened in patients with very low left atrial compliance, and in patients with severe severe aortic regurgitation, and the effect of LV diastolic dysfunction is also difficult to assess, but it does impact the mitral valve flows. So you just need to keep that in mind. This measurement is less reliable in the elderly, probably because of the high incidence of diastolic dysfunction as in that population and as we age. All right, we can also use the continuity equation to estimate mitral valve area, and this method is based on conservation of mass, that the volumetric flows through the mitral and aortic orifices are equal. So simply the cross-sectional area times V1 equals the cross-sectional area times V2. And when we extrapolate this to echo, what we end up with is that the mitral valve area times the mitral valve VTI should be equal to the cross-sectional area of the LVOT times the LVOT VTI. And when we rearrange the equation, so the MVA, mitral valve area, is equal to the cross-sectional area of the LVOT times the LVOT VTI divided by the mitral valve VTI. And so how we measure this is firstly in the parasternal long axis view, we measure the LVOT diameter, and the machine uses this diameter to calculate the LVOT cross-sectional area. And then you trace the LVOT VTI, which has been measured with pulse wave Doppler in the apical 4-chamber view. And this gives us the LVOT stroke volume along with the LVOT diameter. And then thirdly, we need to trace the mitral valve VTI from mitral valve inflows, which we've measured from pulse wave Doppler in the apical 4-chamber view. And then we can the machine plugs those values into an equation and will provide a mitral valve area. The advantages of this technique are that it is reasonably independent from flow conditions. The disadvantages are that you need multiple measurements, as just described, and therefore there are multiple sources of error. And it's not valid if the original condition that flow through both volumetric flow through both orifices is equal. So in the case of MR or AR, flow through those orifices are not always equal, and likewise in AF. So it's not valid in those conditions. You can use the pulmonary artery stroke volume to plug into the equation, but that's a little bit harder to image, in my opinion. So I don't do that unless I have to. Okay, PISA, which is actually a level 2 recommendation, but sometimes it may be necessary depending on what other conditions the patient has and where there's discrepancy between values. But so the proximal, PISA is proximal isovelocity surface area, and this method's based on the hemispherical shape of the flow convergence of diastolic mitral flow on the atrial side of the mitral valve. And that's shown with color Doppler. So you might remember from the mitral regurgitation talk, we were interested in flow convergence on the ventricular side of the valve. In this case, we're interested in looking at flow convergence on the atrial side of the valve. And mitral valve area can be calculated with that, reasonably long-winded equation listed on the slide there, where R is the radius of the convergence hemisphere, or the PISA radius in centimeters. And that's actually R squared. Not typed particularly clearly, but R becomes R squared. The V aliasing, or the aliasing velocity, is in centimeters per second. And then we have the peak V mitral is the peak continuous wave Doppler velocity of the mitral inflow. And then A, or alpha, listed on the slide, is the opening angle of the mitral leaflets relative to the flow direction. This method can be used when there is significant MR, so sometimes you have to use it if there's mixed mitral valve disease, but it is technically challenging for a number of reasons, particularly measuring that alpha angle. That's something that takes a fair bit of technical expertise to get right. And with so many variables, again, there are many opportunities to increase, to include or insert, error. It is a level 2 recommendation from the American Society of Echo, so it's not something that's part of my routine practice. And if it was getting to the stage where we needed to do this measurement, I would be asking for expert help. All right, moving on to mean gradient, which is the other main contributor to the grading of severity. So continuous wave Doppler is the preferred method to ensure that we're actually capturing maximal velocities and recording them. You need to line up the continuous wave Doppler as well as you can in the direction of the blood flow, And then velocity is converted to pressure using the modified or simplified Bernoulli equation. So this is most commonly done in the apical 4-chamber view. It can definitely be done in the apical 2 or 3-chamber view if you're unable to line it up satisfactorily in the apical 4-chamber view. And it's a good idea to recheck your measurements in other views as well. So practice it in the apical 4 and the 3 and the 2 when you can. Mean gradient depends. So after you've CW'd through the valve, you then trace the spectral waveform. Mean gradient obviously depends on the mitral valve area, but also on the transmitral flow rate. And the transmitral flow rate depends on heart rate and cardiac output. And the transmitral flow rate, and therefore the gradient, will increase as heart rate and cardiac output increase. So it's important to note and document the heart rate and I guess cardiac output if you've got it, but make some note particularly about the heart rate when measuring the mean mitral valve gradient. Concurrent MR will also increase the transmitral flow rate and therefore the mean gradient. Peak gradient is of really no interest here. So that depends on peak velocity, which is increased by LA compliance and also diastolic dysfunction. It's also important to look for associated features when you're assessing for mitral stenosis. So look at the left atrial volume. You'd expect if there's significant stenosis, there'd be LA dilatation. Look for the presence and absence of MR. This has implications for methods of grading, but also implications for choice of treatment down the track. Look at the other valves. Aortic stenosis is frequently demonstrated in patients with mitral stenosis of rheumatic origin. Look at the right heart size and function and also pulmonary pressures. Okay, we can look at some slides, some loops. So this is a parasternal long axis view, zoomed out. And I think obviously what stands out here is the huge left atrium compared to the other structures in the window. The mitral valve leaflets, we are zoomed out, but they do look thickened and their mobility looks restricted and abnormal. And if we zoom on that a bit further, what you can see here is the hockey stick appearance, hockey stick doming of the anterior mitral valve leaflet. And this is characteristic of rheumatic mitral valve disease, this hockey stick pattern. And then M mode through the mitral valve leaflet tips. And this is demonstrating restricted leaflet mobility or an abnormal motion. So it doesn't have that, particularly the anterior leaflet, doesn't have that nice biphasic peak of mitral valve opening. This is a linear measurement of left ventricular diameter as an indication of left ventricular size. And look, that's within the normal range, but we'll need more information before we make an accurate comment about LV size. And here, colour's being placed over the mitral valve. And it's zoomed out, so it's a little bit hard to see. What you can say is that there is some flow convergence on the atrial side, indicating high velocity through the mitral valve, and there's no significant MR, which is important when we're trying to grade the severity of the lesion, but also for prognosis and treatment down the track. And now zoomed in even further on the valve, which again is demonstrating thickened mitral valve leaflets that aren't opening normally, like we've seen in previous loops and previous presentations, and that hockey stick appearance of the anterior mitral valve leaflet characteristic of rheumatic mitral valve disease. And zoomed in with colour, I think the flow convergence on the atrial side is more obvious here. It's easier to see. So you can see the blue and yellow hemispheres converging at the mitral valve orifice. And it's probably even a bit more obvious there. And that's just a still image really to demonstrate the hemispheric flow convergence on the atrial side of the mitral valve when it's opening. And that's indicating high velocity through the mitral valve. So it's also important we look at the aortic valve. And here we've got two normal looking leaflets, thin, mobile, opening well. And place colour over the aortic valve there, and that looks pretty normal to me. That doesn't indicate any significant regurgitation, which is important for us to know if we're using grading methods for MS. This is how we measure LVOT diameter. And now we've moved to the parasternal long axis view of RV inflow. So this is a beautiful RV inflow image. So we can see the tricuspid valve opening and closing nicely in the middle there, separated by the right atrium at the bottom of the screen and the right ventricle right at the top of the screen. If we put colour over that valve, we can see some TR there. And then continuous wave Doppler through that TR jet to measure the TRV max and therefore pressure gradient to calculate our RVSP. So that's already significantly elevated. And this is another beautiful image of RV outflow, which is tricky to obtain sometimes. So from the parasternal long axis view, the transducer beam is being tilted up towards the shoulder. And we can see right in the middle there the pulmonary valve with the right ventricle at the top and the main pulmonary trunk underneath it. And here is where you would measure the RVOT VTI if you wanted to include that as part of the continuity equation. And now we've moved to parasternal short axis view. There's a lot to look at here. In the middle is the aortic valve. On the left of the screen is the tricuspid valve. On the right of the screen, you can see a little flash of the pulmonary valve. So it's the RV outflow tract heading down into the pulmonary arteries. And at the bottom, you can see the big round left atrium with the interarterial septum bowed towards the right throughout the cardiac cycle, which is indicating high left atrial pressure. And then all of those structures will have colour put over them. So this is colour over the aortic valve, looking for aortic regurgitation. And I can't see any there. And then zoomed in, it's very important here again to look closely at the valve and make sure that you can see the three leaflets separated and opening well. And that looks quite normal. And then again, just looking at the pulmonary valve, colour over the pulmonary valve, and there's a small flash of PR there, which is very common. And just zoomed back out again, and some colour zoomed out, and you can see these are really lovely images. Not only that flash of PR, but you can actually see the right and left main pulmonary arteries there. And if you're really unlucky or lucky one day in your career, you might see some clot sitting there as a saddle embolus. Move over to the tricuspid valve. Again, you can see that tiny flash of TR. And again, continuous wave Doppler through that TR jet so that we can calculate RVSP. And now we've moved down towards the mitral valve level, or we're at the mitral valve level in the parasternal short axis view. And here you can see really thickened, calcified kind of mitral valve leaflets, and they're not opening nicely in the way that we've seen in previous images. And you can also see what looks like an enlarged RV. That's certainly the impression in this view. And there's septal flattening as well, indicating high right-sided pressures. So there's high velocity flow, blood flow through the valve. Again, it's hard to comment on exactly what's going on here, and I'm sorry I can't slow it down for you, but we would need to slow this image down and work out whereabouts in the cardiac cycle that high velocity flow is occurring to comment on what it exactly is. Zooming further in on the valve just to really demonstrate the abnormalities of thickening and reduced opening. Moving further down towards the apex, so this is the mid-pap view in the parasternal short axis. Again, you can see that D-shaped septum, septal flattening. And moving further down towards the apex, which that's not the true apex, but they're getting down towards there. So next we move to the parasternal, the apical four-chamber view. I guess the thing that jumps out immediately here is the grossly enlarged left atrium. The LV looks like it's contracting okay. The RV looks like it's contracting. You get the impression that the RV is probably about the same size as the LV in this image. And so there's probably some RV enlargement there. And even zoomed out, I think we can appreciate the restricted opening of the mitral valve, especially when you can compare it to the tricuspid valve. The LV volume has been measured, and it's significantly enlarged at 78 mils per meter squared, which I think we'd already appreciated visually. Zoomed in on the mitral valve in the apical four-chamber, again demonstrating leaflet thickening and reduced opening. Colour through the valve. So this demonstrates a couple of things. So there is some MR there. There's an eccentric kind of posteriorly directed jet. And there's also, I think in the zoomed out view too, you can appreciate the high velocity with flow convergence through the mitral valve from the atrium to the ventricle. So this is a continuous wave Doppler through the mitral valve, trying to capture that mitral regurgitation. And look, it's not a whole signal. The bit that we can see is quite dense, but it's certainly not a whole holosystolic dense signal. And again, this is zoomed in on the valve with colour, really demonstrating that high velocity with flow convergence through the valve. Oh, sorry, and that was a still image, just to show you. So there's the dark blue, light blue, and then yellow hemispheres as we move from the valve leaflets in towards the atrium. That's the area of flow convergence, and that's where you'd measure the piezo radius. So this is looking at mitral inflows. So this is similar pictures, but this is kind of the raw CW of mitral inflows. And what they have done here with this image is just optimized it a little bit. So they've slowed it down and changed the scale a little bit and reduced the gain. And the way that I was taught and was described is that you want to trace the chin and not the beard. So you want to avoid getting all of those little wispy bits at the top there. And in that way, you'll get the most accurate representation of the mitral valve mean gradient. And so by tracing around those CW spectral waveforms, we've got a mean gradient of 20 to 22. And you can see how they've traced a couple, and that's good practice to make sure that you're getting a consistent reading. So now they move back into the zoomed out apical 4-chamber view, concentrating on the pulmonary valve with colour. And from here you could do pulmonary vein flows. And then now we're looking at an RV focused view. I think grossly the contractility looks okay, reasonably normal. And an RVS prime has been measured, which is 10.1, which is normal. And then again, looking at that TR jet with colour flow Doppler. And that's giving us a TR Vmax of 4 meters per second, corresponding to a pressure gradient of 62, which again is consistent with the elevation that was demonstrated before. These are linear measurements of the RV size, which are actually within normal range. And now we're in an apical 5-chamber view. So from the apical 4, the ultrasound beam has been tilted slightly superiorly, and this images the LVOT and the aortic valve. And here is where you would use pulse wave Doppler to measure the LVOT VTI. And that's used in conjunction with the LVOT diameter that you measured in the parasternal long axis view. And the machine has calculated a mitral valve area using the continuity equation. So it's calculated a mitral valve area of 0.59 centimeters squared, which is very small. It's far less than 1, so that would be severe. And if you plug the values in, just as an example, that's what it looks like, so 0.6 with a bit of rounding is the same as 0.59. Zooming in on the LV to have a look at its function. And then moving to an apical 2-chamber. Again, we're looking for the same things. Colour, and there is a little bit of MR there again, and we can see that flow convergence through the mitral valve as well. Important to interrogate that MR jet in other views, and again it's showing it's a dense but kind of incomplete signal. This is probably in the moderate category. And now we've moved to the apical 3-chamber view. And again, we can perform the same measurements and take the same pictures, looking at the mitral valve in particular, and also repeat the LVOT VTI if we're unsatisfied with our apical 4-chamber images. Zoomed in, again, you can see that classic hockey stick appearance of a rheumatic mitral valve. And we've moved to subcostal views now, and this is focusing on the IVC. What we're looking for here is collapsibility. So is there a 50% reduction or 50% collapsibility in the diameter of the IVC? Probably not quite 50%. And this linear measurement demonstrates that the IVC is dilated as well at 2.3 centimeters or 23 millimeters. So then retrospectively, sometimes it's easier to go back once you've taken all the pictures and then do the polymetry. So in 2D, the mitral valve polymetry is 0.9 centimeters squared, which would put the stenosis in the severe category. And then this is just demonstrating that you can get 3D and 4D images to help, perform that measurement as well, if you have the skills and the technology. With 4D polymetry, the mitral valve area was 0.8 centimeters squared, which is consistent with the 2D. They commented in the report that according to pressure half-time, the MVA would be 1.2 centimeters squared, but I couldn't actually find the images. Anyway, this is how you would do it, and I'll show you another example in the following slides. So for this patient, we have mitral valve polymetry of 0.8 to 0.9 centimeters squared, indicating severe mitral stenosis. The mean gradient through the valve is 27 millimeters of mercury, which again is consistent with severe stenosis. And other supportive features included significant left atrial enlargement, but also raised pulmonary artery systolic pressure. We do need to keep in mind that this patient was tachycardic, and most measurements were performed between 100 and 120 beats per minute. So that may falsely elevate the mean gradient, but certainly the MVA by polymetry was in the severe category. All right. So this is another patient who, again, has an abnormal mitral valve. Looks reasonably similar to the last one, actually, doesn't it? So again, we're in the parasternal long axis view, and here we can see a grossly enlarged left atrium. We can see a mitral valve which appears restricted in its mobility. The leaflets appear restricted in the mobility, and that they're not opening normally. And again, we can see the hockey stick appearance of that anterior mitral valve leaflet, which is consistent with rheumatic heart disease. And that's zoomed in to demonstrate that a little bit better. Another demonstration of just the linear measurement of the left ventricular internal diameter. And now zoomed in on the aortic valve. Important to look here to see if there's concomitant aortic valve disease, but these leaflets look thin and mobile and appear to be opening normally. Again, important to measure the LVOT diameter so that we can use it as part of the continuity equation later. Colour over the aortic valve, there's a trace of aortic regurg there, but nothing significant. And you can also see, it's not focused on the mitral valve, but you can see, we'll get the impression that there is a bit of MR and some flow convergence. M mode through the mitral valve, just like before, this is demonstrating significantly restricted mitral valve opening and restricted mobility of particularly the anterior mitral valve leaflet, which is demonstrated by the absence of that biphasic peaks of opening. Just zoomed in again, more images really thoroughly interrogating the appearance of that mitral valve. And then colour. So there is a jet of MR there, which is reasonably centrally directed. It's certainly not wall hugging. And you can also see flow convergence on the atrial side of the valve as the ventricle fills. And here's another image of the same things. Zoomed in even further. And sometimes it's helpful to look at images side by side as well. This is CW through the mitral valve. And I guess this illustrates the important thing that we've talked about a number of times, is if the Doppler cursor is not lined up with the direction of blood flow, you're going to significantly underestimate whatever you're trying to measure. So as you can see, this really isn't capturing that MR jet at all, because in this position, it's impossible to line up the cursor and the direction of the MR blood flow. So by tilting from the parasternal long axis, by tilting the beam inferiorly, we can image the RV inflow again. So there's the tricuspid valve in the middle, RV at the top, RA at the bottom. And those tricuspid valve leaflets look normal. And there's no real appreciable TR there on colour Doppler, maybe a tiny bit. But CW nonetheless, because there is enough there to get us a continuous wave spectral display, which is indicating a TR or a max pressure gradient of 44 millimeters of mercury. And now we've tilted from the parasternal long axis, tilted the beam up towards the shoulder to bring in RV outflow. Again, quite hard to get this view, so it's good to show you another nice example. And in the middle there you can see the pulmonary valve opening and closing with RV at the top of the screen and the pulmonary artery inferior to the valve in this image. Colour over the valve, I think there's a hint of PR there. And here again, we've measured the RVO-T VTI if you want to use that later on. Parasternal short axis view at the base of the heart. And again, what's predominates this image, I guess, is the huge huge left atrium with septal bowing. Other structures we can see right in the middle is the aortic valve opening and closing, the tricuspid valve to the left, and the pulmonary valve with RVOT and pulmonary arteries to the right. Zooming in on the aortic valve to really make sure that there's 3 leaflets and that they're opening and closing. And then colour over the valve, looking for AR. And there isn't any. Beautiful image of the tricuspid valve in the parasternal short axis. Leaflets are thin and mobile, opening and closing. Colour over the valve to show that little bit of TR. And then again, continuous wave Doppler of the TR jet so that we can use that to calculate RVSP. I'll just go back here again. You can see the left atrium with the septum bowing significantly into the right atrium throughout the cardiac cycle, which again indicates raised left atrial pressure. So now we've moved to the mitral valve level in the parasternal short axis view. We can see here the mitral valve is barely opening at all, really. The leaflets are very thickened, and you can see commissural fusion again, which is characteristic of rheumatic mitral stenosis. Colour over the valve does demonstrate some MR, which we've seen in previous images. Zoomed in on the valve, which demonstrates those findings even more clearly, so really reduced valve opening, and the commissural fusion is nice to see there. Um, 2D mitral valve area by polymetry is measured here at 1.1 centimeters squared, so technically moderate. Measured again at 1 centimeter squared, right on the cusp of severe. And moved down to the mid-pap level in the parasternal short axis view. Here we can say, I mean, we haven't really commented so far, but LV function looks reasonably normal, and septal motion looks normal as well, so there's no septal flattening or D shape of the septum. And move down to image the apex of the heart. And they've also used some other, 3D and later on 4D for polymetry to measure mitral valve area, and this measurement's 1.2 and 1. And this also demonstrates, where they're lining up. If you look at the panel on the left, helps them work out where they are, helps you work out where you are in the valve in terms of the aperture. But this is more kind of advanced sonography. And 1.1. And there, 0.9. So it's all around the 1 centimetre squared in terms of mitral valve area by Polymetry. This is a lovely apical 4-chamber view. Again, really, really large left atrium, which kind of attracts all your attention. And a mitral valve that looks like it's not opening normally, even in this zoomed out view. Measured the mitral valve, the left atrial areas, which are converted to a volume. So it's at 123 mils per, 123 mils per meter squared, which is grossly enlarged, which we'd already demonstrated. Now colour through the mitral valve, so we can see that jet of MR, and also I think can see the flow convergence at the mitral valve. And this is CW through that MR jet. So what we're interested in is that flow below the baseline. And again, it's reasonably dense, but not a full signal. Probably fits into the moderate category. And again, just pan through the valve at a slightly different angle to demonstrate that MR. And using the same image, I guess, so it's all CW through the valve, but they've just changed the angle a little bit. So now we're really looking at flow through the valve from the atrium to the ventricle, so above the baseline, with continuous wave Doppler. So tracing around that CW spectral waveform will give the mean gradient, and then the purple dotted straight line tracing down the E wave deceleration slope is how you measure the pressure half time. And putting that line in means the computer will calculate it for you, which is amazing. So those images give us a mean gradient of about 15 in one and 12 in the other, and a mitral valve area by pressure half time of 1 centimetre squared. Zoomed in on the mitral valve, demonstrating the findings that we've already discussed. Colour through the valve, so again we can see that jet of MR, but we can really see the flow convergence where the mitral valve is opening, and the high velocity through the valve. And that's a still image demonstrating the flow convergence, and this is where you'd measure the alpha angle and the Pisa radius if you wanted or needed to. And that's an example there of the Pisa radius being measured. It's a little bit tricky to see, but they've measured the radius of where it goes kind of yellow, blue, dark blue. So that's the flow convergence area. So here they're looking at pulmonary valve, pulmonary vein, which is right at the bottom of the screen. And interrogating pulmonary vein flows, which will help when in the setting, that there's MR, to make an assessment about whether or not that MR is significant. And you can see here the S wave is bigger than the D wave. It's a bit hard to see, but it's labelled 1 and 2. So that's not consistent with severe MR. Oops. RVS prime, 9.5, very, very slightly reduced, which I think is consistent with the visual appearance. That the RV function doesn't look significantly depressed. And again, colour over the tricuspid valve there, looking for that TR. And the pressure, or the velocity measure is a little bit less there, but probably due to angle. These linear measurements indicate mild dilatation of the RV, so less than 42 millimeters or 4.2 centimeters at the base is normal. Now we've moved to the apical 5-chamber view with a lovely LVOT aortic valve in the middle there, and colour over that. So there's a tiny bit of AR, but nothing too significant in terms of colour flow, and then pulse wave Doppler in the LVOT, and use that in the continuity equation if we want to. And by continuity equation, it's indicating quite a small valve area, so 0.65 centimeters squared. Oops, sorry, that's just a picture of continuous wave Doppler in the LVOT or through the LVOT, and that spectral display above the baseline is representing that AR, the aortic regurgitation. So there is a little bit there. LV function looks reasonably normal. And then we've moved around to apical 2-chamber. Again, the grossly enlarged LA just takes over the whole picture. Colour through the valve, demonstrating the same findings as before. So you can see that blue jet of centrally directed MR and the flow convergence at the mitral valve opening. Zoomed in again. And colour at the zoomed in view. You can move to the apical 3-chamber, which again nicely demonstrates the restricted leaflet opening at the mitral valve and that classic hockey stick appearance of rheumatic mitral valve disease. And then colour over the mitral valve, which is consistent with what we've seen before. And if you want or need to, again, you can repeat measurements here. So this is the CW through the mitral valve, where you could trace for your mean gradient and also do a pressure half-time. And then this is also CW through the valve, but they've just changed the baseline and the gain a little bit, and that demonstrates that little bit of MR as well. And again, an example of measuring the mean gradient and pressure half-time. And almost there. So here again, we're in the subcostal view, looking at the IVC, and this IVC does demonstrate at least 50% collapsibility. And is just on the cusp of being normal size, so very, very, very slightly enlarged. You could probably call that normal, to be honest. 2.1 is normal. And in this patient, they did move on and do 3D and 4D planimetry, which are beyond us, but nice pictures to look at. And with 3D, the 3D planimetry, the MVA mitral valve area was 0.7 centimeters squared. So in this patient, the mitral valve area was reported to be less than 1, which fits it into the severe category, and a mean gradient of 24 millimeters of mercury, which is supportive of that severe categorization. And other supportive features were the gross LA enlargement and also a raised pulmonary artery systolic pressure. So again, that echo would be consistent with severe rheumatic mitral stenosis. All right, that's the end of the talk. Thanks, everyone.